steps or where there might be areas that we can help.
Yeah, thank you, Timmy, and good morning, everyone. Happy to be here to talk about this STAR HIE grant. Let me share. I got a few slides that I like to share. Are you able to see the slides?
Mm-hmm. We're in.
Excellent, thank you. Let me put it. Okay, great. Just a quick background on Lanes for the folks that are not familiar with us. So we are an independent nonprofit organization which have developed a community-based health information exchange for Los Angeles County and Greater Los Angeles area. Our provider network has grown in the last 4 years that we've been in operation. We've got some of the largest health systems participating on our network, and currently we are at 9 million unique patients in our clinical repository, which includes clinical behavioral health, and we are adding the SDOH data this year. And as a public benefit organization, our goal is to drive change for the good of the public, and which will be measured by the impact on the healthcare ecosystem and outcomes. So this HIE, the STAR HIE grant, and STAR stands for Strengthen the Technical Advancement and Readiness of Public Health via Health Information Exchange. This grant was awarded to us in January of 2020. It's a one-year cooperative agreement with ONC for just over $123,000. The program objective, as it states here, is to align HIEs with public health agencies and leverage the clinical data held by HIEs to support enhanced knowledge sharing around COVID vaccination. So we actually started on this right after we were awarded. Some of the milestones that we had to achieve was develop legal arrangements between the partnering organization and the first phase of this project. And then also kind of working with DPH IT team to establish a process for accessing the vaccination data. That part of the work took a long time to get those agreements in place. And there were really two steps. We had to work with the California DPH for them to authorize the county DPH to share their vaccination data with Lanes. Took several months to get that data sharing agreement finalized and executed with the county council. And then we had to, another kind of part of the work was to work with DPH IT team, which had multiple levels of approval to establish a secure FTP and access to the vaccination data. And then that was a big hurdle as well in getting those approvals from the IT team. And finally, we were able to access and access that data. The technical task of ingesting and rendering vaccine data had its own challenges, but they were within our control, and we were able to get that data, ingest it, and then render patient vaccination status on the CCDs and the portal for the providers, get it in the hands of the providers. The phase 2 of the project is to enhance our current infrastructure to support the stakeholders' reporting needs, and that will be DPH as well as our provider. And we leverage the cloud and big data to manage a large volume of data that we were handling. And the use case for this project was to identify high-risk patients that have not been vaccinated and notifying their primary care providers. And the final milestone or task was to close the gaps in the current surveillance system with real-time clinical notification and electronic case reporting to DPH. This diagram shows the process and the data flow. On the left side, starting on the left side from here is that we received this immunization history from DPH and going through the whole process of patient matching, which I'll talk in a few minutes, and then basically ingesting the data into our clinical repository. The arrangement with DPH was that since we have, to kind of filter that data and just use the ones that we have a exact match. And so we'll talk about that in a second. So the left side is basically receiving the data, ingesting it into our system. What the right side is showing is that taking that raw data and making it useful and actionable and present it to them, put it in the hands of the providers. So we'll talk about that in the next couple of slides. As everyone is aware, patient matching and patient identity matching is a big problem in healthcare. We use Verato technology that gives us really good matching rate, high matching rate, I should say. And so in this process of filtering, we identify the patient demographic traits and pass it on to Verato, and then process the ones that they match, and then filter out the ones that they don't match per our agreement with DPH. And then once we get that, so currently I think we have what they presented to us was about 18 million records, and we are almost at 10 million records that I was informed yesterday that we were able to ingest and match with our system.
Ali, can I ask a question there? So with those
Sure.
that fall out, do you have a process to go back to DPH to figure out to do better matching, or you just wait for the next run?
Yeah, we wait for the next run. So what they provide to us is a cumulative batch. So we've noticed, we've received, I believe, 3 batches so far. We get a monthly batch from them, and it's cumulative. So some of the ones that we could not match in January, we are able to match in February and March.
I have a couple of questions here. Deanne?
Hi, Ali.
Hello.
Sorry if I missed this. I'm staring at why it's the county. I know, of course, Lanes is county, as opposed to California Department of Public Health or CARES 2. I didn't even know the counties had this data.
Yeah, good question. No, I didn't either. So we thought that we had to start with the data. So we approached California DPH, and we also had conversation with the local DPH, the county DPH. The county kind of confirmed that they have the full set of vaccination data that the state has, but they couldn't release it without getting authorization from the state. So we had to go back to the state and describe what we are trying to do here, obtain that authorization. Took several months to do that, multiple iteration. There was a change of guard at the, as you know, at the state level. So, we started, and then there was kind of a start and stop type of a process. Finally, they give us authorization. And then at that point, then we had to get into the contracting discussion with local DPH for sharing that data.
Great.
Robbie?
Yeah, actually, I think this one's a sort of a follow-up to Deanne's question, but we've heard before in presentations that there have been discrepancies between the data in CARE2 versus the Snowflake platform. And I think we're curious, which are you receiving immunization data from?
It's not a snowflakes. It's
Okay.
coming from the DPH, local DPH, and it comes in the form of a batch file.
Got it. Okay. Okay. That's helpful.
I think we interrupted you here, Ollie, but we'll let you finish and then we'll have more questions, I'm sure.
Yeah, no, no problem, no problem. Yeah, please feel free to ask questions as we go through this. I got 2 or 3 more slides here. So notification use case, this is identifying high-risk patients that have not been vaccinated and notify primary care physician. As I mentioned, to fulfill this aim of the aim of this use case, Lanes is utilizing the BigQuery data store to identify the cohort of patients for which a COVID-19 vaccine immunization record exists. We are using CDC guidelines. This is per DPH recommendation to use CDC guidelines for definition of what's high risk. And the challenge with that was that the CDC guidelines are just mentions the medical conditions like diabetics or asthma, but that is not coded. So we actually had to convert those medical conditions into ICD-9 codes, and then use the provider rosters to identify primary care providers, so we can use we can notify them, and then we use the BigQuery or the data from the BigQuery to pass it on to the Lanes Smart Alert application for the patient PCP notification. The Smart Alert is a tool that we have to notify providers are very familiar with it for ED admits and inpatient admits. So they're very familiar with that product. So we are kind of adding a tab to that application for the notification of the high-risk patients that have not been vaccinated. So, kind of lessons learned and challenges.
Ollie, just for
Yeah.
a provider, from the provider standpoint, they get a list that they can then ingest into their EHR, but they have a list that they can work off. It's not like this one by one.
That's correct. Yes, it's yes, they get a list. So challenges that we experienced was obtaining, as we talked, and Deanne asked, so obtaining that legal approval to receive the immunization data, obtaining approval from the BPH IT to establish that secure connection. That was a surprise to us, that how many levels we had to go to really gain access to that data. Defining the architectural and workflow requirements, especially when it came to using the BigQuery and big data on cloud-based systems. Identifying high-risk patients by diagnostic codes. That was also unexpected that we had to do that ourselves. Obviously, we have a CMO on board and working with DPH, we were able to get that at the point of, that we're all comfortable with those conversions. And then correlating COVID vaccination immunization with a patient PCP. That was also a bit of a challenge. Where we are right now, as far as our project status, the initial data extract supporting the identification and immunization patients are complete. As I mentioned, we are sharing that with the providers. Lanes is now receiving a monthly batch of vaccination data. Patient vaccination status is included in the CCDs and on the Lanes portal. The Smart Alert dashboard, the content and user interface is in development and should be in progress. It should be done by the end of this month. And then we are developing training material that's being developed to train our users. So that's kind of a short summary of what we've done with this grant. ONC gave us a no-cost extension through end of June to complete this project, mostly because recognizing how difficult it was to get those legal barriers, or to overcome those legal barriers. Happy to answer any questions.
This is fantastic. Thank you so much. And I think it's proving out what we had hoped we could have done 6 months ago, right? With our discussion. So I guess I would just ask, what can we learn from that long process, painstaking process that you had with getting the agreements together? How can we make that something that can be replicated with a lot less time, a lot less runway? Like, is there something that we can do to really say, okay, here's the language, we've all agreed to it, up and down the state, let's just adopt it? Like, is there something we can do there?
Yeah, I think there are some administrative policies that can maybe be relaxed at the state level to be able to share this, public health data with HIEs. I think that, the advisory committee on this, the stakeholder advisory committee, that there has been some discussions around that. I think it's a good time to bring that up and have these, at least HHS or the legislature to kind of relax some of those. And they're administrative tasks. They're not HIPAA. So I think that would be helpful for other HIEs to get access to that data.
And have you had feedback from the providers as well? Are they able to consume this and have action on it? Or is it just sitting out there and, and they wish they could?
Well, I mean, they are receiving that information, so they have access to it. But to answer your question specifically, we're kind of waiting to see this notification of the unvaccinated. How does that help them, and whether there is a follow-up to that, and there's an intervention by the provider to reach out to those high-risk patients that have not been vaccinated.
Mm-hmm.
And what the result of that. So that we're not there yet, but that's something that we will be interested in kind of finding out. But in terms of, they have access to that data, so I don't really know how useful that is for them to know that, okay, their patient have been vaccinated.
Yeah, I just recently had a mammogram reminder, PSA, everybody go out and get your mammogram. But they asked me for if I could remember when my last booster was, or my last vaccine, and I gave the date. I'm like, I have it on my phone. I can give that all to you now, because now I'm on, I got the Fire app on my phone, and they didn't want it. That was good enough, and they just kind of put it in, but they didn't have the actual data, which just really, we have so much improvement to make.
That's right. A lot of room to improve. Yes.
Any other questions? I'm going to open it up.
I was going to ask you, Ali, is there any plans to expand the breadth of the data you receive from DPH to other registries, like the cancer registry and such? Have you had any thoughts or talks around that?
We not at this stage. No, we have not. We're very interested in that. We are connected to CARE, and we are connected to CURE's database, but with local DPH, the conversations that we've had is about kind of augmenting some of their data with the clinical data that we have. That's more of a longer term projects, not within the scope of this grant, but that's something that they are interested in. We're also in discussion with California DPH, so something similar to that, kind of augmenting some of the data gaps that they have.
And Ali, how about working with health plans? Are you providing the same data to your health plans as well?
They receive, we did offer this to the health plans, but they're already receiving it through that Snowflakes and directly from the state. So they already have that data.
I know I'm tracing that back to Sharon, your use case where there was added value that the HIE gave you.
Yeah, we
above and beyond what you got from the state directly.
Yeah, we did it a little backward from the way that Ali is describing with lanes. So we approached it from the health plan perspective, went to MX and said, hey, we can get all this data on, we can get it from the registries, we can get it from CDPH. We got it from the registries directly first. And then we eventually got it from CDPH, and then we fed it to MX. And then they fed it back to us in a prioritized list. So so then we did two things with it. One was to drive a campaign for member outreach for the folks that needed those vaccines the most desperately, critically, and then also to inform the providers on members that or patients, their patients that had those gaps. The interesting thing about the member outreach, which we thought was what our primary focus was, is that the outcomes of that were not very impressive. It was just really hard to get a hold of members and get them to to sign up to get those vaccines if they were lacking them. But we do have a robust repository now of all that information, which has been really helpful. The HIE, again, like Lane's we're looking at, is that's the integral component here, where we really need to be using it for these kinds of challenges that help really share that data to the broader population and start to drive some of these initiatives. So it sounds like we're all tackling it very similarly.
Agree. Yeah.
And I'll just add to, I think we're going to talk about this a little bit later in the deck, or in the meeting, that other states had more reliance on HIEs were able to put their social determinants of health data. So maybe that would also help.
Correct.
In understanding what some of those barriers are as to why the vaccine wasn't being.
Yeah, and that's to the degree that the HIEs have the SDOH data, right?
Exactly.
An area for improvement as well.
Yeah, we're not there yet here.
Yeah.
LA County, though, has some pretty progressive data sharing agreements. There's actually legislation in place to share data extensively for child investigations in the case of referrals, and then also for individuals, for adults or families experiencing homelessness. Data can be shared across multidisciplinary teams. They don't have a technology mechanism for the second one, they do for the first. So it would be interesting to see kind of what opportunities that would then provide for lanes, because that data would also be tremendously helpful to the healthcare providers.
Sorry, Mary Sarah,
Yeah.
did you say Sonoma County or Solano?
No, LA.
LA County, okay, thank you.
Yep.
It sounds like an area to follow up.
Yes.
That's right. Yes, I'm making a note here. Yes.
That's connecting the dots. I love it. I love it. I love it. Okay, I'm just looking at my time here. Any other questions? Ollie, thank you so much. I'm just leaving it up there for questions. Raise your hand. Okay, Ollie, thank you so much for joining
My
us.
pleasure.
Welcome
pleasure.
you to stay on. We're going to be talking about the budget items and also doing some debrief from the data exchange framework next.
Sure. Thank
So
you.
terrific.
Thanks for the update.
Terrific. So moving, I think if we go back to our deck. Trying to just, we prepped on how to have the conversation today around what we heard from the last data exchange framework advisory group. For those of you who tuned in, I think it was much more of a, how would I qualify it? Give and take, back and forth than we typically have heard. And the topic of the day was governance. There was a lot of pushback from some stakeholders who were asking why they were looking at governance models when they felt like it was premature without a acute agreement or an agreement on what the functions that would be governed. So we thought today it would be good for us just to walk through what was put in front of the advisors as the key areas of functions that would be governed. And then we also have a slide on the straw model or straw dog, as they've called it, of what the governance model might look like. And we just love for us to spend, the next 10 to 15 minutes here to get your input and understand if as a coalition, we might want to put a collective point of view together, or go and do some additional research for you to come back with some items that we can discuss. So these are the core governance functions that were put in front of the advisors. I'm going to let you, take a look at them. I think many of them, for the most part, folks agree that there needs to be some level of oversight and an ability to make changes and to maintain and escalate where needed. There was quite a bit of discussion around enforcement and how enforcement would be maybe a different lever here than what already exists across the state, the state regulatory bodies as well as those legislative bodies. So I don't think that there was any really good outcome around the idea of enforcement. But when we took a look here, I think what we didn't hear discussed, we wanted to capture, because I think it's really important for us to get a little bit more detail around what expectations are from stakeholders for governance. Maybe what I'll do is kind of run through this and then open it up for your ideas and your insights. Really quickly, harmonization of state law and federal law, where we'd really like to know what laws those are. It seems like we're super high level and know what laws need to be harmonized. When looking at the development of policies and procedures, it's unclear to us whether or not the policies and procedures are going to be developed as part of this process and submitted in the June-July timeframe, or is that something that would come after? And we're questioning why we wouldn't be doing that now, and what is the timeline to finalize them. And then there's this idea of enactment of data sharing policies and procedures. Is that now? What is the timeline? What does enactment mean? There was the federal standards and national efforts, being to review them, but we would think that there'd be more than review. What's the representation we would have? How do we escalate? How do we make change based on what California needs? When looking at enforcement, really identifying if that includes carrots and sticks and what are the levers that they're looking for. I think there was some discussion around a hybrid model. I think we could all agree that the regulatory bodies could potentially be a really good enforcement mechanism, but for some bodies and stakeholders, that just doesn't exist. Looking at dispute resolution, how do we collect disputes? How do we escalate those? On the program development of financing, knowing that it's going to take much more than just public financing, but what does that public-private financing look like? And how do we get technical assistance out, not only for the the private stakeholders, but public stakeholders as well? How do we get agreement, as Ollie was saying, from the attorneys at different levels of government to be all on the same page? Looking at identification and qualification of exchange intermediaries, we think we all agree, and there's a process already in place with CalHOP. Can we just use that? On communication and education, we've agreed that consumer literacy and health literacy is super important. And then trying to run through this, the ongoing review of the data sharing agreement. Yes, we agree with that, but there needs to be changes. How is that going to be done? How will it be promulgated? Is it annual? Is it monthly? And then there's a whole body around, there's this idea of coordination with other branches in state government. I think we've had big discussions around not only coordination, but some kind of oversight, and where and how can we compel, local government, as we just talked about, and it looks like we're starting to do this through legislation, to participate in data sharing. And then also, of course, all the other registries and other data sources that sit in other silos of government. And then finally, what wasn't mentioned here was identity management, that we have this whole body of work on, the NPI that hasn't been discussed, at least I haven't heard, patient access to this data, and then just overall, what is the roadmap and strategic planning? What does that look like? So that's our brain dump from staff. I'd love to hear if you're able to take a look at this prior to the call, or maybe we can bring this up on our next call too. John Ohanian, who leads this work, is going to be joining us. So I think we can do some pre-work on coming up with some really nice questions that he can address that are important to us. But I'll open it up. What do folks think? And I see some of you on camera. I might call on you.
Oh, I wanted to mention Deanne's point around what's in the statute around making sure that there is a common set of policies and procedures submitted to the legislature. So yes, that's within the requirement for what the agency should be submitting to the legislature this summer.
I haven't heard it being mentioned, or I haven't heard of any effort to be able to get that going. If anybody else has. Lori, you're bringing up the SHIG.
Yeah, I think we discussed this briefly at the advisory call, and really this issue of harmonization of state law, item number 1, and really item number 4 as well. A lot of this has already been addressed over the years. The SHIG is a nice, sort of baseline document that we've all worked on. So again, a lot of these things are just sort of updates to what's already in place and really addressing it, with the exception of this policies and procedures, and then the enforcement and monitoring component. We heard on the call a pretty strong discussion about enforcement, but it's hard to enforce things that do not have a common policy and procedure in place to begin with. So,
Right.
So I think in terms of sequencing all of this, the recommendations to all of these are going to have to follow in order. They can't be done simultaneously. So, so there was fairly good discussion, and I'll be curious to see what John took back from that discussion as well.
Reed?
Yeah, thanks. I'm looking at this for the first time, so just sort of reaction / question. Row 11, obviously, like wanting to ensure coordination across government, and the context here, and this is certainly like my lens anyway, is through CalAIM, larger recognition of just the role of SDOH and social care services. I'm wondering, well, one, flag important to ensure that departments and agencies that have long been working in the space of community are part of this governance.
Yep.
Two, I wonder if that was actually like raised or brought up in the actual meeting yesterday. I know that SDOH has always been kind of woven through these data exchange frameworks, but it of course and naturally is clinically focused.
I have to go back and look. We can send to you the those that are on the data exchange framework advisory group, and what they're represented. I know for example, I'm speaking with WIC through the introduction with Katie at ITEP. And I think it's super important that we start getting really good insights and needs represented.
Yeah.
On this. Yeah.
Perfect. Thank you.
I agree. Yeah. My sense of when I saw, and I don't know, for those of you who were here 10 years ago with this work that we did, Lori, I'm looking at you, when I saw coordination with other branches in state and local government, my heart dropped, because it's more than coordination. There needs to be, some absolute participation and oversight, and just what Ollie described of the multiple layers that are barriers, frankly, for data exchanging. If you don't have that leadership to be able to get through those barriers, it's not going to happen. So there's something there.
100%.
Yeah. I think that was when we had our health IT czar, which was, I was reminded that was what we called it, Jonah Froelich with the health IT coordinator, and then Pam Lane after that. There was really no teeth to be able to compel different registries and social services and other, even county data, to be part of this data sharing initiative. Anything else? Do you think there's any big pieces that we've missed? Thank you, Reed, for bringing up social services.
Timmy, we've got 2 more hands. I think Karen, you had your hand up next.
I didn't see it. Thank you.
That's okay. Thanks, Timmy. Thanks, Robbie. I think for me, the thing that I've been thinking about just over the last couple of days after that conversation was, and several of the advisory group members talked about this, and I think this gets at the heart of some of the concerns that were expressed early on, was AB 33 charges Cal HHS with developing this thing, but not actually giving them statutory authority to govern this. And so I think that's what's standing out to me is without statutory authority, so like a follow-on legislation that gives Cal HHS statutory authority over this, then it could potentially just perpetuate the situation we're in. And I think that's where the part of that, like I said, that concern from some of the members is, we're kind of jumping a few steps here, because that authority hasn't been established yet. The frame or the proposal that was put out last week clearly puts Cal HHS in that role. And so I think that was just a big gap. And I'm curious to see, I saw some heads nodding, so I'm curious to see if others agree that there's a gap there, and any reaction to that, because that's a big, to me, that's a big hurdle, and I think it's at some of the concerns that were raised.
You just hit the nail on the head with what my frustration that I was just expressing. So thank you. Let's keep that in the front, and let's make sure that that's asked. We'll queue that up as a question when John joins.
Awesome. And Doug, you had your hand raised too.
Hi, Robbie, and thanks for inviting me. And this is my first time here, and so sorry if I'm repetitive or overstepping my bounds in any way. I wanted to bring up the point and kind of dovetail of what you said about the governance and oversight of this. We passed that along, and it kind of touches on 1 and 4 with these federal standards. Now, we have standards that FQHCs must adhere to. And if they don't adhere to these standards, and one of their standards is having contact and engagement with all the members that are assigned to them. If not, they lose that reimbursement. They actually have to pay back. It's a more complex formula than that, but that's simplification of it. Why don't these same standards apply to like big plans like LA Care that holds the majority of Medicaid in California? And if we apply these governments over them instead of, we've been letting kind of the fox watch the hen house with them, and obviously they've been in a lot of trouble and failing many audits and everything like that. We need to take that authority back and put it back at the state level. And I mean, that's my suggestion. If we're going to push for legislation, we need to build a stronger government oversight when it comes to that mandatory member engagement for members receiving benefits.
Thank you. And also, I think there's that was mentioned in the governance discussion around how do we ensure that the consumer is part of the governance function. And I think what you're mentioning is not just, but promulgating that along all the actors. But that's also something I think that we should make sure is considered.
Yeah, it just that, I ran the numbers and I could see how much from my informatics standpoint, how many members just don't have any engagement throughout the year at all. Not even one office visit, a simple 99213 follow-up office visit. So if we could see that data, then we can act on that data. And so, and why we need to ensure, I mean, there is a rule for when members get auto enrolled into these Medicaid programs, which mostly are LA Care, and then there's a few big players like Centene and Molina. And I used to work for Molina for 8 years, so I have a lot of insight with them. But the thing is, they have that 120 rule. They're supposed to have engaged that patient in 120, but they keep on diverting to a technicality that they just have to have 3 attempts. And then they write it off every year saying that they did these 3 attempts and they couldn't get a hold of the member. How long are we going to let this pass? Because all of those people are still getting other government benefits, still have a social worker, and still connected to the Department of Social Services. So we need to make sure that all players involved with that members benefits in the state of California that we're providing to them are involved with the bigger picture and are accountable to making sure that they are engaged with their healthcare.
I think it's right to the heart of the matter, and how do we have the data and how do we act on it? So thank you. And I'm just looking at our time here. I think we have, Robbie, do we have our other presenters on?
Yeah, I think we can move ahead to, just because we're short on time, to our presentation on SB 1033, and we'll hand the floor over to Andrea from California Pan-Ethnic Health Network.
Thank you. Hi, everybody. Apologies for being a few minutes late, but definitely appreciate the opportunity to share more about SB 1033 with this group. This is a particular bill that CPAN is very excited about because it is related to the issues around demographic data collection and the wide racial and ethnic disparities that exist in healthcare because of that. And so I know that I was able to share, oh, great, I just saw Robbie drop some of the language in the chat. There is a fact sheet and other materials that I'm happy to circulate with the group if they haven't been circulated already. But just really going into some of the background here, SB 1033 is really sort of a revamp of existing law. And so in 2003, CPAN and Western Center on Law and Poverty authored SB 853, which is called the Healthcare Language Assistance Act. And this particular act was one of the first of its kind in the country at the time. And what it really sought to do is require health plans to provide language access services to patients who were in need. But it also included some pieces around ensuring that health plans are collecting demographic data. So things related to race, ethnicity, sexual orientation, gender identity, age, and so forth. But what we found 20 years later after the application of this bill is that demographic data is still very varied in terms of its completeness. And so this has really hindered the ability for the state of California and for leaders, as well as statewide advocates and community stakeholders, to really be able to analyze what kinds of resources are helpful to provide, in particular to historically excluded communities. So thinking about BIPOC Californians, LGBTQ folks, disabled Californians, and those kinds of groups. And so with SB 1033, we're really focused on the demographic data piece and not just going back and addressing some of the issues that popped up in the application of SB 853, but then also starting to analyze what are additional forms of data that are not currently being collected, but can really be beneficial for improving health outcomes of specific communities of color. And so some of the things that we're looking at are, making sure that private health plans are able to develop confidential demographic profiles of the patients that they serve. These profiles would be private. All the information that is provided would be held with the utmost, regard to make sure that information is secure. But we're really looking at specific kinds of information like age, sex, race, ethnicity, disability status, SOGI data. And this is all for the purposes of really identifying and then addressing racial and ethnic health disparities. That's one piece of SB 1033. The other piece is not just sticking with the traditional forms of data collection like demographic data, but what else can we do as a state to go even beyond that and make sure that we're analyzing health-related social needs data or information that's related to the social determinants of health. And this is really important, for communities of color, because we know that things like housing, public safety, food security, all these issues really do impact how Californians are able to live healthy lives. And there is no current structure for collecting this type of information from patients and therefore being able to analyze it along with demographic data so that the state can really determine how we should be allocating resources in order to address health disparities. Some of the other things in SB 1033 is really looking to establish a technical assistance fund. And so we know that obviously, there's going to be a lot of standardization in terms of the types of data that should be collected, best practices for how to improve data collection, and really codifying that this is, a responsibility on the commercial health plans to uphold their ability to do this. And so part of that is making sure that plans also have the ability to receive technical assistance or training so that they're aware of what are these changes? What are those best practices? Things around demographic data use and making sure that patients feel comfortable. And this is really important, especially when thinking about BIPOC folks, because there is, increased levels of, folks not feeling comfortable sharing their personal information. So we do realize that there is a need to make sure that plans and providers also have the training and capacity to be able to work very closely with community members to help them feel safe, and so that they can also, help provide this specific information at different points of care. Just some other things related to SB 1033. We also really want to make sure that the data collection practices are culturally and linguistically competent to the best of the ability. And so this is also going into the training and technical assistance. And then we also want to include some provisions that would allow folks to put self-reported data, in addition to making sure that plans are doing larger sample sizes when they're doing surveys, because we know that these are also things that folks currently don't have the ability to do so. And when it comes to making sure that data is collected in appropriate ways and best practices, self-reported data is actually one of those mechanisms that is one of the most successful. That is the broad overview of SB 1033. And I know that I shared a lot of information. And so I do want to pause here to see if there's any clarifying questions or perhaps some details that would be helpful to really hone in on that I did not mention earlier, or if folks just have general questions too. I'm not sure if the fact sheets were shared with you all.
We shared them out with our meeting materials. So for folks who are on our distribution list, it was sent out. And Andrea, maybe what we can do is if we get any more questions, we can send them your way.
Yeah, that would be great. What I can do is drop my email in the chat box. And if folks have any questions, we're really looking to make sure that this is not just an effort that is, within just solely health spaces, although this coalition obviously is made up of a lot of groups that are involved in these spaces, but we know that, and you all know that when it comes to demographic data collection, it's not just about making sure that we have the information that best applies for how we can improve healthcare access, but it's really about how we can improve more long-term and start to reduce, these health disparities, and making sure that we're coming up with more of these long-term solutions for how the state can definitively say, these communities like Asian Pacific Islander communities, for example, that really suffer from the lack of demographic data, have the resources that they need to really be able to make sure that individuals that are a part of those communities are able to live full and healthy lives. And so I will drop my email in the chat box. One other thing that I will mention as it relates to this bill, it's likely that it will be heard in Senate Health Committee on March 30th. We're still working on scheduling a date for that. But the bill has already been referred to Senate Health Committee. And so if there is interest or perhaps you have other questions, I'm more than happy to set up one-on-ones or, respond to emails from folks and share some of the materials and also see how we may be able to bring you all in support of this effort.
Excellent. Thank you so much, Andrea. We'll make sure to share that information with the members and follow up with you too if we get any questions. Thank you so much.
And I think we'll entertain support on a future meeting too. So everybody take a look at the materials and let's talk. This is just spot on with what we've been talking about for the last year and a half. So, or yeah, last year.
And I think we had one more item we wanted to get to with David, just around a budget proposal around HIE technical assistance for small and safety net practices that was heard in Senate Budget Subcommittee last week. David, thanks for joining. I think we just wanted to hear a little bit more about the budget ask and where you envision the ask going to.
Sure. Well, thanks everyone. Sorry I signed on so late. I did warn Robbie I was actually presenting on a separate webinar about telehealth policy that, if for those of you who follow telehealth know, that whole world just blew up yesterday. So my webinar went a little longer than I expected because there was a lot of breaking news to cover in that world. So shifting gears, so let's talk about health information exchange. Again, David Ford with the California Medical Association. So CMA's interest here is really with the small practices. We're also thinking about the other safety net settings, the FQHCs, some of those other settings. And last year in Assembly Bill 133, we had actually requested that there be language put into 133 that those providers in those safety net settings that are under-resourced, that oftentimes have less robust EHR systems, don't have IT staff to work with. We had actually asked that they not be brought into the data exchange framework unless and until the state developed a project to help them get there. Now, we all know, CMA and me and the position I was in at the time at CalHIPSA, we were the instigators of what was the CalHOP program. And we really thought that was going to cover it, but we all know sort of CalHOP got delayed and delayed and delayed. And by the time it really got up and running, well, the HIOs did a really historic, really heroic effort to try to do what they could in the time that was allotted. They didn't have enough time to really do what they needed to go chasing around a bunch of small practices. So we still have this sort of huge unmet need, even post CalHOP. And now we have this data exchange framework coming, at these small practices. The state wasn't willing to write the language quite as strong as we wanted it to say, no, they don't have to participate unless and until they get a technical assistance program. What they did do was give those practices 2 years of extra runway to be compliant with the data exchange framework. So if you see that, that's in the law. There's this group of practices to get 2 additional years to 2026. You move down a little bit in the law, there actually is a reference to the state doing a technical assistance program. It's in subsection G for those of you who are wonky and want to pull the bill. So it was written into the budget last year, but there was no money put into it. So it's great for them to say, we're going to do a technical assistance program, but of course, no money, there's no program. And the state told us at the time, like, yeah, we don't have time to work that out this year. We'll work with you on it next year. So back in the fall, we developed a proposal of how that could work, what it could look like. It's an $80 million proposal. We actually spread it over a few years to lower the budget hit for each year. That includes, actually has some overlap with 2 other things that are going on. One, some of you may be aware of the $400 million practice transformation grant program that's being worked out in the legislature. There may be some overlap between what we're trying to do and those grants. And we have had some conversations, me and Claudia and Felix, about seeing if we could reconcile what we're looking for with this $100 million ask that this coalition is supporting. We couldn't quite figure it out. We're still trying. We're still talking about that. It'd be great to get it to sort of one place. But suffice it to say, we're really looking at three big things in our proposal. One really is technical assistance. That's sort of at the elbow, sit down, in the practice support for small practices. Here's what you need to do. Here's how to use the HIE. Here's how to work it into your clinical workflow. The work that I'm very familiar with from my time at CalHIPSO, we still think there needs to be a component of that. A second component that is sort of CalHOP-like that is about subsidizing interfaces. We all know those interfaces are expensive. They've been a challenge for providers since the beginning of HIE, but we want to create a subsidy fund for that. The third piece of it is about office infrastructure upgrades, a grant fund for office infrastructure. You know, we're talking about a lot of practices that may not have really good wiring for internet in their practices. They may not have servers. You know, they may need better computers. You know, just have a fund to help them upgrade that internal office infrastructure. That is where we actually think that may overlap with the practice transformation grant. And if the state may say, no, that's over here, you don't get it over here, so be it. Now, you know, and as I say, as I've talked to Claudia about what you guys are driving at, I think they're kind of two different looks at the same thing. I get where, you know, and we're actually supportive of both proposals, as you know, but we do think there is still a component that is needed that is this very specific focus on these safety net practices that goes beyond, you know, we do like the fund that your proposal creates, this sort of support, you know, provider bonus fund. I forget what exactly you guys call it, but we're still missing that sort of on the ground, at the elbow education component that unfortunately, you know, we used to be able to pay for that sort of thing through high tech, and we don't really have a good way to pay for that through the federal process now. So our proposal is also a little different from yours, and ours is just straight general fund. You know, we look at it and say, you know, the state sat on CalHOP for 2 years. They kind of owe us this piece in our minds. They've got a $50 or $60 billion surplus, so we're just going for it, straight general fund ask. Both proposals were heard in the Senate subcommittee last week. I think it was last week. You know, and I think we're all, you know, we have the exact same question you do, which is we don't actually know where the administration's going. We've heard all these rumors that the administration is developing some proposal for the May revise, but they've been incredibly tight-lipped about what they are thinking or are willing to do. So we're continuing to push from that regard. I know you guys are over time, and I'm the last speaker and the last signed on late, so that's my quick once over. I don't know if you guys actually have the fact sheet for our proposal.
No, that would be great to get that. And David, what, in terms of like next steps or opportunities for, you know, either organizations or potentially this coalition to support, kind of what are next steps on the proposal and how can folks get involved?
Sure. So the next steps, it's exactly the same as your proposal. It'll be heard in another budget subcommittee, and then I think apparently I can't. I don't know if there's something with Zoom. Apparently I can't drop things in the chat box. I'm trying to drop it in there. You know, Robbie, maybe I can send it to you and you can send it around.
Okay, perfect.
But if, you know, so we would love to have folks support it. We would love to figure out how to work with you guys, how to talk about, you know, how our thing fits with your thing. People have asked us, are these conflicting? And I keep saying, no, I see it as an and, not an or. There may be some overlap. And then I think it really is just that what you guys are doing, what we're doing, it all drives at really talking to the administration and explaining the need for this work. You know, I think, you know, that while we have the data exchange framework, I think what we sort of heard back from the administration, I know that there's been some indication that they believe all of this should quote unquote be privately funded. I think that's very challenging. And I think the other thing that I have heard from the administration, they are very, very focused on CalAIM. They're very focused right now on how basically the counties and housing departments and city public health departments and all these folks are going to fit into the world of data exchange. They're not really thinking about sort of the unmet need in the provider world. And I think that's the piece that we can all work to educate them on, is why what you're doing, what we're doing, why all of this is important and why we're doing it, because there is still this massive unmet need.
Agreed. I think, you know, I think wherever we can support these types of asks, we should be really kind of pulling together. I think we have to be strategic about it, of course, but I really appreciate, David, you know, looking out for where there's needs and highlighting that for us. If you can give us the fact sheet, that would be great. It sounds like, what's the next step? And I know Felix, you're on. I don't know if you're still on. We're over time here. Is Felix still on?
Yeah, I'm here.
What are next steps for both of these to be able to be heard in the budget?
Yeah, well, I think David was on point there. The next steps, I mean, the Senate has officially heard not just our respective proposals, but the entire litany, right?
Yeah,
in the health
which, by the way, nobody
health.
could get through to be able to do public comment because it was so long.
That's right. That's right. Yeah, I suffered through the operator queue as well. On the assembly side, David, correct me if I'm wrong. We had heard from like the staff and the committee that they aren't actually going to have like a similar omnibus read through. Obviously, they still are going to entertain stakeholder proposals. They have a whole separate process where you need an assembly member to officially sponsor your request to have it move through the process. I think that's the case for both of our items, and yeah, I think it's less sort of like the public-facing hearings and more the individual behind-the-scenes engagement with legislators and their members between now and the May revise to continue pumping up the forward momentum for these requests, for any requests that stakeholders are putting forth in the governor's budget.
And as you presented last time, Felix, that there's that folks can connect to you for doing some of that behind the scenes work, especially if you have government relations arms as part of your organizations. I would have them connect with Felix and or IHP, right, who's heading up that work. And then David, should they connect to you to coordinate? And then it sounds like Felix and David, you're also trying to figure this out too. Okay, David, David, do you want to drop your email in the chat? All right, well, we've got some movement here. We've got one piece of legislation. We'll probably be seeing more, I'm guessing. David, I wasn't aware of the 400 million transformation grant. Is that a piece of legislation, or what's that taking?
That's actually
equity ones, correct?
Yeah, that's and that actually is something that it is an official proposal from the administration that CMA worked with them on actually through the fall. That is essentially creating a grant fund. The original thinking was to help small practices in particular recover from the pandemic and start to build towards the future. I mean, folks can look at it, but it's if it survives its current form, it does actually have some funding in there that can be used for IT related stuff, including one of the things they particularly talked about was upgrades to electronic health record systems.
Great.
So it's another sort of piece to the puzzle in this whole thing.
Okay, terrific. We'll continue to track that as well and keep us updated, please.
Of course.
We're way over time, but thank you, David. Thank you, Felix, for those updates. We'll continue to kind of save space as well. I just want to quickly go through the calendar events, make sure you all have this on your calendar. If Robbie, if you could throw back up, or Kira, the deck. So if you haven't seen our roundup for this week, please take a look. There's several items that I think you all will appreciate. I'm going to not even step on these, although we will take time on them later. Let's keep going to the calendar. There we go. So just want to highlight for you that there is a hearing next week for the Prevent Pandemics Act on Tuesday, the 15th. I believe it's in the morning, our time. Our staff will be covering it, but I think there's some hope there that there might be some additional funding at the federal level for HIE. And then also, I'm sure HIMSS is going. I think several of you or some of you may be going. I would welcome you to kind of do a meetup. The staff is not going, unfortunately, this year, but we will be there next year. But I welcome you all to do a meetup. And then just take a note of all of the digital identity work that's going on. RIM Cawthorn, who's leading that work for the state, did an ask for health plans. So if you or your colleagues, Sharon, maybe you can send out a note to your colleagues to be able to join the health plan discussion around the identity management. I'm happy to work with you on that, but I think we should heed his call and make sure that we're a part of those discussions. And then also, we had initially thought we would do a listening session on behalf of the state, but I think he's getting his input elsewhere. But I would still like to entertain, if we want to have our own listening session or workshop, that we can then create either a fact sheet or a letter back to the process. We'd be happy to do that. So if you all want to do that, please let me know. I know we had some discussion on it. We'll do some follow-up outside of this call. But I think if there's interest, we'd be happy to facilitate a discussion. And our next meeting is on the 24th. As I said earlier, John Ohanian, who leads this work for CHHS, the data exchange framework, will be joining us, which I think is fantastic. And we'll be doing some pre-work, and I put it in the chat. If you have questions, I'd like to give him some questions that he can use to prepare for the discussion. So please send those to me if you have any that you'd like for him to cover. We'll take some of the discussion from today too and shape that for him. And in addition, we have IAHP coming on board to talk about their incentive program, that if we could have an ideal state would be all of our MCOs, our managed care plans, would have something like that in place. So again, if you or your colleagues have interest in learning more about what they're doing, please come to that meeting. And I think that's a wrap. Thank you again, everyone, for joining us today. Take care.
Bye, everyone.
Thanks, everyone.
Bye-bye.